This week on the BackTable podcast,
I find that frontal endoscopic sinus surgery for acute infection is probably the hardest thing that we do because people are trying to find the true drainage outflow pathway in a field of super swollen mucosa, and then being confident that you kept it open is the tricky part. And so that's why a lot of people just do trephinations, period, because they're not 100% sure that they got that frontal open. And so there's some tricks that you can do, I think, to kind of maximize your outcomes there, because I think those cases are the highest risk for going back to the OR in 3 or 4 days when the kid's not better.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. My name is Gopi Shah. I'm a pediatric ENT, and I have a very special guest on today for a really, really important topic. I have Dr. Amanda Stapleton. She's a pediatric otolaryngologist and endoscopic sinus and skull-base surgeon at the University of Pittsburgh Medical Center, Children's Hospital of Pittsburgh. She is the fellowship director for pediatric ENT and the director for the Center of Sinonasal and Rhinology Disorders. Her research focus is on the bacteriology of pediatric chronic sinusitis and of patients with cystic fibrosis. She's been prolific in her research contributions to pediatric rhinology and her contributions to rhinology education through the academy. I got to know Amanda a little bit better working alongside her on our fellowship committee through ASPO, as well as on some of the ACGME milestones that we did for the ENT fellowship. It is with great pleasure that I welcome you to the show, Amanda. How are you?
I'm doing well. How about you?
Good. I just want to tell you, I don't think I ever told you this, but I remember when I first started my practice a couple of years in, and we started to really want to develop a real pediatric sinus and skull-base center at Children's. And I started to look at my own patients, and then I'm like doing the literature search, and I just see Amanda Stapleton. So I knew your name, and I was like, who is Amanda Stapleton? and then we got to be on the fellowship committee together, and I was like, okay, all right, cool. And then, last year we got to do a panel together. So anyway, so it was cool to match the name with the face and then get to know you. That's been more fun.
It's always funny because I always think that I'm the only person in the world that cares about pediatric rhinology. Everyone thinks that everybody just has kids who have runny noses and that's the end of the story and they'll grow out of it and, move on in life. So I've always found it much more interesting than that, and trying to get other people super excited about pediatric mucus has really been hard work, but we're getting a few more people on board to actually, care about it. So it's been exciting to see other people develop that area and start to try and study it from a truly objective standpoint. And for me, I try and always look at what's happening in the adult world and see how it does or does not apply to kids. So I'm always looking for new ideas or new approaches to kind of how to manage these patients that roll into our office every day.
Absolutely. And so just for our listeners, Amanda, tell us a little bit about yourself and your training, because you're double fellowship trained.
Yeah, so I did, a regular ENT fellowship or residency, and then during residency, I had the awesome opportunity to be a part of the skull-base community at Pittsburgh, which really revolutionized how we do endoscopic skull-base surgery. At the time, the fellows who were there were like, you know what, you like kids and nobody else wants to go to Children's. They're like, hey, you should really think about pediatric skull-base. And at the time, there was no such thing as pediatric skull-base. Adult guys would just go over to Children's and do cases, and that was it. I knew after making my way through residency that I really wanted peds to be my base practice, meaning the population that I take care of, but I didn't want to lose that awesome endoscopic skill set that we slowly develop over time as residents and fellows. So I did a pediatric fellowship first, and then after that did the adult endoscopic skull-base fellowship so that I would have the skill set to hopefully be able to take care of these patients moving forward.
That's awesome. And you're right. There's something that it's taking care of kids, even when it comes to something like skull-base, to the runny nose, to cystic fibrosis, allergic fungal situs, whatever, chronic sinusitis. It's just a little bit different, right, than treating adults. Even the way the system is, or in your clinic to the hospital to how you pre-op the patient is going to be a little bit different. And so as an adult person having to come over to the Children's every 4 to 6 weeks, even if you got to reset your password, it takes a little bit. And so it is nice when there's a peds person that can really understand how it works, take care of the patient, and also do the surgery and take care of the post-op. So we're going to talk today about intracranial complications of acute sinusitis. It's a good topic because there's some case series out there, there's some papers, but, in terms of how people practice, I think it's still a little bit variable, whether, we're talking about what the role of sinus surgery is not, when to watch, if you do watch, etc. But before we get into all of it, tell us first how these patients usually present to you.
We've all been more acutely aware of these cases because it seems like they've been rolling in more frequently over the past 1 to 2 years, kind of post-pandemic. And so at least in our practice, we even went back and looked at the data to see, hey, are we getting more orbital complications specifically of sinusitis compared to if you took 18, 19 and then compared it to 21, 22. And we saw a slight uptick, maybe 5 to 10% more. And maybe it's just, it seems like a lot when you're on call and, every time you're on call, you're taking a kid to the OR for an acute complication case. But definitely this fall, it really started kind of ramping up in October in our area. I'd say once or twice a week, we're taking a patient to the OR either to drain an orbital abscess or address a intracranial abscess or a frontal, osteomyelitis. And so these kids frequently, unfortunately, roll in pretty sick. They roll into the ER and either one eye is swollen shut, or in the case of intracranials, you really have to worry about more the systemic presentation. Kids are rolling in lethargic. Maybe they, have nausea and vomiting. When we're getting to the point where they're rolling in with seizures, then you're really nervous. Are we dealing with something really aggressive or big, whether it be a intracranial abscess versus just an epidural or subdural? It's rare for kids to just show up in the ER with yellow stuff coming out their nose. Most of the time, it's not even that they have a bunch of sinus symptoms. Parents will say, oh, well, they had a cold last week. We got some amoxicillin from our pediatrician. They seemed okay. And then today their eye is so swollen they can't open it. Or I noticed that their forehead looked puffy. Or they just don't seem themselves. So I brought them in and my pediatrician just told me to go to the ER. They show up in the ER. Somebody decides to get imaging on them and then they call you.
Yeah, you're right. They're usually either in the ER sick, or already taken to the ICU at that point, and then through the scans. And by the time they've called you, the patient's already in the unit. I remember, especially my first few years out, thinking, man, we're not used to seeing kids with neurological signs and symptoms, right? Most of them will have headache, nausea, vomiting, but when you have that first kid, the child that has the dysphagia or the upper or lower extremity weakness, or it can be a little bit, it's pretty scary just because that's not in our normal symptoms, right? We have the clogged ear, the runny nose, things like that. And the other thing, like you said, with seizure, sometimes it's hard to know, is this how involved intracranially? Those are the red flags. But sometimes it is hard to say how much of the physical exam finding is actually correlated with the imaging, right? Some kids look pretty good and you're like, you got a pretty big intracranial abscess in there, And so sometimes the symptoms can be that scarier than sometimes a scan and vice versa. And in terms of eye swelling, do you find, I think I found this in my clinical practice, but I think I read a case series. Do you find that your lateral orbital abscesses have a higher predilection for intracranial, or do you think that matters? Because I think I read maybe it was 10% of orbital complications can also have simultaneous intracranial. What do you see?
Well, it really, I think, depends on age and location. We see a lot of just confined orbital complications that don't have intracranial. Those tend to be the medial orbital wall, subperiosteals that really aren't draining all the way back, making it to the cavernous. But if you're talking about a teenage boy who's 16 and has real frontals, meaning truly pneumatized sinuses and has a bad frontal acute infection that also led to the floor of that frontal sinus easily drains through the orbital kind of veins, and then does that then get you an epidural abscess posterior to that? So the medial ones I don't really see tend to truly go intracranial, but it can be like bad frontals that can start to really back up and, start to spread more into the intracranial compartment.
And you're right, it's usually that sort of, we say the adolescent males, and we say that because the frontals tend to pneumatize, right, during adolescence. They start to, you have more venous supply and an easier way for spread as there's more development through, whether it's through blood, direct contact, etc. But, it's crazy. Every once in a while, it's not common. I'll every once in a while have a younger kid. And so that does have some pneumatized frontals, or younger kids where it's like sphenoid. The disease is posterior a little bit. Tell me about some of those patients.
Yeah, so I had a case this year of a 9-year-old who had isolated sphenoid sinusitis. I mean, all the other sinuses looked beautiful on the CT scan that he rolled in with, and he rolled in with new headache. And he was a kid who never had a headache. Parents were physicians. They were very reliable in terms of symptoms. And he had a new headache that he'd never had in his life, and little family history of migraine, but it was just that it was so distinctly different than anything he had ever shown up with. And when you looked at him, he, had had a cold for a week, had a history of adenoiditis, was getting a sleep study for possible sleep apnea just because he had moderate adenoids and moderate sized tonsils, and then rolls in with a cavernous sinus thrombosis from isolated sphenoid sinusitis. So, and he was 9, he wasn't the 16-year-old boy who sat at home for 2 weeks, never told anybody he had a cold, and then rolls in with a giant frontal Pott's puppy tumor or something around those lines. So,
absolutely. So in terms of physical exam, do you do anything special? Like, are you scoping any of these kids? I mean, I know it's kind of a ridiculous question now that I ask it out loud, but a lot of these kids can be young, or if they have such bad headache, or they are, altered mental status. And also, I don't know if once you have that imaging, if putting a scope in is going to change your management.
A lot of times these kids roll into the ER overnight. So the first people that tend to see them are my residents, and they do tend to scope them because they're trained to scope everybody. And we're not talking 3-year-olds here. I mean, most kids 10 and up can handle a bedside flex scope, no big deal. I always tell them that if you see pus, culture it, because sometimes that can be helpful, especially if they can tell me, there's purulence coming out of the middle meatus. I cultured in the ER before he got put on his IV unison, and just to kind of move forward with being able to appropriately treat medically on top of what you'll ever, eventually do surgically. Sometimes it just helps identify purulence, helps you get culture-directed swabs, and just know what you're dealing with. And then, the tough ones are the ones where their nose doesn't look so bad. They're a little bit red, turbs are a little bit puffy, but they're not pouring out thick yellow-green slime. And you're like, well, I guess it all went intracranially instead of coming out your nose because, your nose looks okay. It doesn't typically change my decision-making. It's more just to help with either getting a decent culture on them ahead of time before they start IV antibiotics, or just to know kind of the level of, what we're going to have to deal with in the OR, depending on how edematous they are.
I agree. If you're able to get a culture, that's great. But I think once they come in with an intracranial, and again, we'll talk about the role of FES and, all that in a little bit. But the other things I tend to try to get, if I can, is just a good eye exam, like extraoculars, eye swelling. Those things are important to me. If there is a pot, how indurated, how swollen, how big is it? So that, we have a baseline and something to follow with. And I think the eye exam and the eye swelling, all that's more important to me if there is a simultaneous orbital abscess or post-septal or orbital cellulitis or pre-septal, whatever we're following along, that is important to me. And then if depending on the kid's age and how with it they are, sometimes I'll get my own neuro exam, depending, in terms of nothing crazy, just like grip, shoulder shrug, push on the gas type stuff, just to kind of see what's going on. Tell me about imaging. So I feel like most of the time, the kids, by the time we see them, will have the CT and an MRI. The kids that have the, meningitis or encephalitis, epidural, subdural, empyemas, etc. When do you consider something like an MRV?
And just going back to the physical exam thing, the nice thing with the eye ones is that everybody's got a camera on their phone. Either parents or my residents, we had them take a picture of the eye, because then you can truly say, are you getting better on IV antibiotics or not? That part's nice because you can take a picture every, 12 hours and see, and you can put those in the chart. And then especially those small subperiosteals that you think might respond to IV antibiotics, it is really nice to try and get objective data in terms of, okay, yes, their lid was swollen shut today. Oh, it is improving. Or yes, we are getting good movement. So that's important too in terms of if you're going to take a kid to the OR or not for an orbital, drainage. So in terms of the imaging, a lot of times they roll into the ER and they get a CT scan, right? And whether it's a CT head or a CT max face, hopefully we're at the point now where they're ordering a max face because we're assuming that the ER is suspecting sinusitis, especially if it's orbital swelling that they're looking at. They don't always have an MRI. There's the fast MRIs, right, that they do to make sure nothing big, bad, and ugly is happening. And sometimes if a kid rolls in with neurosymptoms, they'll do that first. But, those are big cuts. They're quick scans just to kind of have a view of, is there something intracranial we have to worry about? The only time that I get worked up about an MRV is truly if we're dealing with that kind of isolated sphenoid. Frontal disease rarely makes it all the way back to the cavernous. Can it happen? Yes. The diploic veins don't have valves, so is there a pathway that you could get from frontal all the way back? Probably. But if you have a decent MRI that's not one of the fast ones, you're probably going to be suspicious of that ahead of time. I find that MRVs are useful if, like I said, we're worried about cavernous sinus thrombosis. Honestly, I use more MRVs in mastoid disease than, I do sinus disease, because I just feel like the incidence of sigmoid sinus thrombosis and acute mastoiditis is much higher than, a frontal causing vein occlusion that then puts them on anticoagulation for, 6 months. So,
yeah, absolutely. And then in terms of the different types of intracranial complications, I do feel that an intracranial abscess is going to be, do you feel like an intracranial abscess is worse than a meningitis? Like we think of epidural, I think the better comparison would be, an epidural abscess and a subdural empyema in terms of aggressiveness of the abscess itself and making the patient sicker, if you will. But do you ever think of it that way in our heads? Should we even be? Does that change how you manage the patient?
So anytime that either epidural or subdural, we're obviously dealing with an aggressive bacteriology or something that has decided that it doesn't want to stay in the nose. So if it's a frontal and acute sinusitis and you have a frontal epidural, I'm less excited about those, meaning I think that, okay, you can either have direct bone extension from the frontal osteomyelitis that you're dealing with, where versus a subdural empyema, it's had to break through that dural wall, make its way back through that kind of blood-brain barrier, to get into the subdural space. And then it's interesting to me because I always assumed in the past that anything that went subdural or intracranial had to, you had to get a cranie, take off the frontal, go in and drain it. And then we had a run where people were doing burr holes just to drain the abscess. And I'm thinking to myself, is that good enough? Is that going to really clean things out so that this just doesn't refill back up? You just think, oh, well, if they just put a hole in and sucked it out, is that going to work? And I think that's some of the debate in the neurosurgical, world is what's adequate and what's not. Once it's a true brain abscess, where we are, looking at an abscess and the frontal lobe is gone or pushed back or, then obviously that kid's getting a cranie, but it really depends on extent. So I kind of rate them the way they are. Epidurals I don't get as worried about. Subdurals, I'm like, this is pretty big. It's really pushed everything back. And wow, that's 4 centimeters of pus. That's a lot of, stuff. And then, once we're hitting brain abscess, then normally it's pretty bad.
And those kids, regardless, and again, we're about to talk about sort of the role of FES, but in terms of talking to the families, once it is a large epidural, subdural, or intracranial, or once it is subdural or intracranial, the course is indolent. It's really difficult to, manage expectations, I think. It's not always a clear cut, and I don't want to say no matter what. There's definitely a range of days in the hospital for these kids, but I would say on average, the child will be in the hospital 10 to 14 days, depending on the severity of the disease and sort of how they do. And especially if they do end up having to go and have a neurosurgical procedure, which it's a coin toss, right? It's about 50%, depending on the clinical picture and the imaging and all that. It's a coin toss almost. In terms of, before we talk about FES, antibiotics, what do you usually recommend? I realize for most of these, I would say our infectious disease colleagues are consulted on board because these can be polymicrobial, they're aggressive, and the child may need something longer term with IV, PIC or something, intravenous antibiotics for several weeks after. But what do you think is important in terms of antibiotic coverage?
Definitely intracranial. I always get ID involved. And for all those reasons, once you got to the point where you got a brain abscess, you're going to be on at least 4 to 6 weeks of something. Our typical teaching was always start them on unison because you're going to cover the aerobes and anaerobes that live in the nose. But sometimes, like I said, they'll broaden it just because we don't have directed antibiotics until we go to the OR. And so they put them on Vanco. It's not quite the, hey, let's put them on Flagyl, Vanco, and unison to cover every possible thing unless there was some immunocompromised state or a kid who has an underlying diagnosis that would predispose them to more aggressive infections. Honestly, most of these are strep, some version of the strep family, strep miliary. There's all kinds of more aggressive strep that has been, what we culture. Occasionally I get staph, but honestly, that doesn't seem to be my number one, thing that's growing out. So putting everybody on Vanc in unison, whether you need to or not, is, I don't know that you always need that extra coverage. But yeah, we pretty much start everybody on unison.
And you're right, it usually is that strep miliary family. Though I think when we looked at our series a couple of years ago, I would say half were polymicrobial. And so some anaerobic coverage. And then ID's always very good at CNS penetration and things that I'm thankful that the ID people are there.
You're like, yes, we will do ceftriaxone. Thank you.
Like age, weight, how often? I'm not sure, but
that's why they train.
Yeah, exactly. Okay, so now let's talk about how do you manage these patients in terms of how do you think about when is surgery indicated for you for these patients?
It truly does depend on what complication we're dealing with and how stable the patient is. I had one girl roll in this fall with a huge intracranial abscess, and the neurosurgery team took her back to the OR that day because she was lethargic and seizing and opened her to drain this huge abscess, and she was very unstable on the table. They were lucky to stop her bleeding. She was so anticoagulated from the infection. I was planning on doing her nose because her frontals were the source of this, but we had to close her up and then come back 3 days later and do her sinus surgery because we had to get her in a better state. She had been down, she was, dehydrated, she was trying to go into DIC, and so we just, sometimes you just have to pick the biggest problem, whether it be the intracranial abscess or, the sinus side. And so when you kind of start from the baseline, I think of acute sinusitis with a preseptal cellulitis of the eye. Those kids are the ones that I definitely sit on longer, especially if they haven't been on antibiotics or if they've only been on amoxicillin and if they're under age 7. I give them a good 48 hours of IV antibiotics, check their eye exam. Optho always follows them with us and does serial eye exams. And if it's under, a centimeter, most of those kids are going to resolve on their own. Once the orbital abscess gets bigger or the swelling isn't better, I'm all about giving people a chance on IV antibiotics. But sometimes when you see the size of the abscess, it's not going to improve. And so I'm more of an early surgeon than a late surgeon. And I think some of that is also comfortability with sinus surgery. Not everybody is a pediatric sinus surgeon, and so some other people that might be in your same call pool would maybe sit on things longer, see if the IV antibiotics are helping, because these are hard cases. These are swollen noses that bleed the whole time. You can't see anything. You're trying to, make sure you get into the right space and drain the right abscess. And so these are the cases that my fellows always say to me, oh, I thought I was a good sinus surgeon, and then this case showed me I'm not, And I'm like, these are why you do fellowship. So I guess we could break it down by if you were talking frontals from a Pott's Puffy versus, a true intracranial from just a frontal sinusitis. So say you have a Pott's, right? And the anterior table is somewhat eroded, not a whole hole, but you could tell that the bone has broken down because he's got a big, egg on the front. So the question with these ones are, number one, how much of the frontal do you take off? Meaning, how much of that bad bone do you have to remove? Number two, can you get there through the nose? Number three, should you just do a frontal trephination and flush out the frontal and put a drain in and flush it daily? If there's an epidural behind the posterior table of that frontal, do you just treat that with an antibiotic versus having neurosurge come in and take down the whole posterior table and cranialize that kid? And so I don't cranialize kids unless the posterior table is involved, meaning that bone's already broken down. We're not talking a frontal sinus fracture here. It's not a trauma, where we know that the nasal frontal recess is never going to work and that sinus is going to always be a disaster and you just need to clean it out to get it, to protect the kid in the long run. I find that frontal endoscopic sinus surgery for acute infection is probably the hardest thing that we do because people are trying to find the true drainage outflow pathway. in a field of super swollen mucosa, and then being confident that you kept it open is the tricky part. And so that's why a lot of people just do trephinations, period, because they're not 100% sure that they got that frontal open. And so there's some tricks that you can do, I think, to kind of maximize your outcomes there, because I think those cases are the highest risk for going back to the OR in 3 or 4 days when the kid's not better, because you thought you got into that frontal, but did you really? And it's so swollen that it's still not going to drain, because you're trying to expect it to drain through 1 millimeter of AP diameter. And so I would say if your frontal table's already injured from your POTS, you do your trephination and flush from above, but you need to make sure it's going down, and so you still have to do endoscopic sinus surgery. And these are the kids that you're using topical epi throughout the case. I mean, you really got to decongest that frontal drainage pathway. I'm not opposed to propels. I think that putting a steroid in there is fine. I'm also not opposed to oral steroids for 3 to 5 days. Our old teaching was that you can't give infected kids steroids because you're going to affect their ability to fight an infection. But when you actually talk to ID and ask them that, short course steroids do not stop your ability to fight an infection. And if you keep a kid on oral steroids long enough to get that frontal mucosa to decongest so that that sinus can drain, and spare them 3 trips to the OR to keep draining the same abscess, then you did them a benefit. So, and then really keeping a drain, sometimes I just leave an angiocath in there, and then every day you can go up onto the floor and flush that. And if it's not coming out through the nose, then your frontal's not open. And so then you got to do something about it. So there's kind of tips, or things that you can do to try and get your frontal to stay open, especially if it's already shown you that it's spreading into an epidural or a subdural, and neurosurge does a burr hole, to clean out the subdural. But those are, I find, the hardest cases, is true kind of acute frontal sinusitis with complication.
Yeah, absolutely. Does neurosurgery ever ask you not to do the steroids because of let's say they do have to do a cranie or a burr hole from their wound healing standpoint? Is there ever that concern?
I haven't had anybody ask me not to, honestly. I try and give them my reasoning too. It'd be like, hey, I know you guys, even if they did a bicoronal, right, came in and did a big cranie, I still think that the short course of it to keep things open and draining supersede, any wound healing concerns.
I've seen a little bit more posterior table, just a little posterior table erosion type of complications. And then in terms of anterior table, I have seen some anterior table erosion as well with a large abscess, right? Like a large superior osteal abscess, the POTS. And so usually what I've done is for the frontals, I've addressed it endoscopically and with my fingers crossed, hoping I'm in the right nasal outflow tract, B, that it stays open, because it's, like you said, it's infected, it's swollen. Even if you think you opened it up, maybe you could have potentially stripped something and then, the Agranasi swollen. I mean, if they have a bunch of anterior ethmoid cells that you can't always predict on the imaging, all of that can be very difficult to but usually I'll try to address them from below, and then from above. Sometimes for a lot of them, I've done more of like a IND, meaning, an incision at the hairline above the abscess, and then maybe get into that superior osteal pocket, get the pus out, and then just tunnel a Penrose in. And then and I learned that from Matt Ryan. He was one of the rhinologists I got to learn a lot from. Actually, he's one of my mentors at UT Southwestern. And he was like, just keep that Penrose in forever, like for weeks, because, right, the bone has osteomyelitis. It's going to potentially pus out. One of my very first cases was actually from the outpatient side. They were able to clear the frontals with oral antibiotics, but the child kept pussing out on her forehead. So she came in, and basically we just did the IND, left the Penrose and got culture. She was on IV antibiotics, and I think her Penrose stayed in for almost weeks, 4 weeks type of thing, until it stopped pussing out. I haven't done as many trephinations, and I don't know if that's just my limited skill set on one hand, and as well as these aren't very common either. I mean, they have their upticks, and when they come in, the IPUS ones are going to come in more often. But I didn't know, when you do leave the angiocath in, how long do you leave them in for?
Well, I try at least 5 to 7 days, or the whole time they're in the hospital. If they're still there, I keep it in as long as we can. It's hard to send a kid home with it, just because you don't know what's happening at home, but just because it's so right in the front. But
mine look like unicorns, straight up. It looks like a unicorn, and I bet they'll milk it out. I mean, stuff will continue to pus out, and
Yeah, I guess that's my question with the Penrose is your anti-gravity there, right? You're trying to, get it to come up.
Yeah.
So do you just have them like squeeze it, or what do you do?
Like kind of massage the forehead a little bit. And if there's still enough stuff there, like you might get a little bit out. Then the question I always have is, when should I take this out? Because I'm like, Dad, it's been like a week or two. Like, like, do I wait? Do I give it the solid 4? In terms of getting the frontals open, are you using 30 degrees? Does that tend to help you? Do you use a big shoulder roll? What other tips do you have?
Yeah, so I always use a 70-degree camera. I think it just is the best for visualization. I always use a fat scope. I never use skinny scopes on children. Everyone gets nervous because they think it's big. And I'm like, the nostril moves, guys. It's soft tissue. You're going to be able to get in there with a fat scope. And then it is important, you're right, to clean out the ethmoids. And I always tell my fellows, never let a middle turbinate stand between you and draining an abscess. And so if you can't see, or you need more room, or especially orbital abscesses, it is okay to take out a middle turb. We do it all the time in sinus or in skull-base surgery. You are not going to give them empty nose syndrome. The other surrounding structures will accommodate that space over time. It is okay to take out a middle turbinate. I know this might be sacrilegious to some people, but it doesn't matter.
No, a middle turbinate scar over, patient had to go back, and maybe the drainage could have been drained, the abscess could have been drained better the first time, but because it was scarred over, I don't think that it allowed it to continue to drain. So no, I've been burned by middle turbinates, both in the acute and the chronic setting.
Yeah, it is okay to take out a middle turb, either partial or total, whatever you need to see and to get where you need to go. So don't be afraid of middle turb resection. Secondly, so I always use a 70 looking up with a fat scope. I always use 1 to 1,000 topical epi on pledgets with fluorescein on them so we don't inject anything. But you really have to pack off that frontal recess, let it sit there, go back and forth if it's, you're doing bilateral sides. And, reverse Trendelenburg, getting the head up, warm irrigations, when you're flushing, you should be using warm saline. That's been shown to help with bleeding. So kind of all those bleeding tricks that we have for the adults, you need to apply to kids too, because you need to be able to visualize so that way you're in the right spot. Obviously, navigation is super helpful in this location. And this is when it's worth knowing how to work your navigation machine, because a lot of times this is 2 a.m. and magically the rep's not there and nobody knows how to turn it on or get things to work. Making sure that you personally, as the, attending surgeon, knows how to troubleshoot your system of choice is really important, because I think in an acute frontal, this is the time to use navigation.
Have you ever one time I used an image-guided balloon for the frontal, and it helped drain some pus. Now, did it help keep the frontal open? I don't know. Was I in the right spot? I hope so, based on the scan. But do you ever use anything like that?
I haven't used that. There are some new systems that have augmented reality, and I have used those. And the nice thing about those systems are you can pre-plan those. So you can trace out where the frontal's supposed to be. And then as you're, navigating, it's almost like following a video game up through the loops to get into the right spot. And normally I do that just to practice with my residents and fellows during non-acute cases, but it can be also very helpful in an acute case because you can preoperatively plan it on the CT, and then, it's when you're in there, it's fairly accurate. So using the technology that's out there can only help us in this situation. And so I think this is a time to really use the new options that are available for advanced level navigation.
Yeah. For these cases, let's say the patient looks more stable than the initial patient you described. And, let's say there is maybe a 1 centimeter epidural abscess let's say it's the ipsilateral side, just, to keep it frontal pacification and some anterior ethmoid and max pacification on that side. What is your threshold for OFS at that time? And what are your goals?
I would take them. Anytime you have an intracranial complication, it's coming from the sinus. I'm very proactive in taking these. I know they're going to need IV antibiotics to deal with the epidural and the intracranial side, but just like an abscess on the neck or in the tonsil, if you don't get rid of the source, what would make you think that it's going to get better faster? And so I think pretty universally, I take these kids back for endoscopic sinus surgery in an acute setting, within a day or two. Whether you have to run in at 1 a.m. for that, it really just depends on if they have sequelae. If they are stable and they just have the bad imaging, I would add them on for the next day and I would do it.
I agree. I think that if anything, like you said, source control is important. I think that having a bug for the IV antibiotics is very important. The question, I think we looked at our series, again, this was a couple of years ago. We tried to look at, does it affect the type of neurosurgical intervention? Did it make it so that maybe they if they did get something, it was a burr hole instead of a cranie. These are limited numbers. I think it was like 25. So we found a trend, but like, what is that? How does that? Usually it's within 24, maybe 48 acts, depending on the time of day in the OR. Sometimes it's hard to get these cases in and they're not 20-minute cases like a neck IND. Like you need some time, and to find that sometimes in this sort of subacute, right? It's not like it had to go at 1 a.m., but now it's turnover time at 3, but I need that 2 hours before the traumas, and we're down to one room, and so sometimes that used to, anyways, that's a whole different conversation, but but we can all relate to that one. And then how often were y'all and neurosurgery going together, you think?
Often, honestly. And then it's always the who goes first game, right? And as, they like to say, the brain's clean. And I'm like, but if the brain has pus in it, is it really clean? Like, are we really going from sterile to non-sterile surgeries kind of thing? And then it's like, whose room is it and who's block time, so.
Those are the little, yeah.
Right. Who's going first or not. And so, we have a great working relationship because we're part of a skull-based team together. So, like I said, we have a good, relationship with our neurosurgery colleagues and partners, but normally I do let them do the intracranial stuff first, and then I'll do sinus afterwards. Ideally, you're doing it under one anesthetic, but again, is that 6 hours by the time neurosurgery goes and we go, and then so you're taking up a whole OR for a whole day or a whole night, depending on when you get to start. Like I said, if it's bad enough that they're either doing a cranie or burr holes are much quicker, so obviously it's easy for them to do that and then me to come in and do my sinus side. But we work in tandem a lot, especially for these kind of complications.
Yeah, I agree. My colleagues at Dallas, at UT, at Dallas Children's were amazing. And you're right, that relationship is established. And so when it is something like this, let's just get the patient better, whatever. In terms of going back to the OR, so when is it ever indicated, and when have you gone back where you saw more than just gradu? That's what Romaine Johnson used to call it, just swollen tissue that looked like garbage.
Right. I think the first question is really, when do you re-image? And so after a surgery, when do you expect improvement or resolution? And then when you re-image, are you re-imaging MRI? Are you re-imaging CT? And then on a re-image, how much of that is blood? If you're getting a CT scan and things look opacified, well, you're like, well, that's just blood. And have you really got your 10-year-old to do his Neilmed sinus rinse for 3 days in the hospital to get the blood? How are we managing that wound, which is really what it is, right? We're trying to flush out a wound, especially if you just did sinus surgery and didn't do external work. I only re-image if I am worried that we're not progressing with symptom improvement. Fevers are spiking again. They're still tired and lethargic. Kids bounce back, right? That's why we all do pediatrics, is because within a day or two, kids are like trying to be their energetic selves, right? And so if a parent's telling me, yeah, it's been 2 days and they're still laying around, they haven't got out of bed, we had a mild fever last night, then I'm worried. Then, like I said, the bigger question is if it was an intracranial complication, then I do MRI, honestly, because I want to know, hey, is that abscess bigger or just not drained? Or because if I did a good sinus surgery, if I need to go back, I'm really just making sure that frontal's open. We don't have to redo the whole thing. If anything, I think of it just like a nice endoscopic debridement. I'm in there cleaning out blood, getting the crust out, that kind of stuff. But if you're worried that your frontal re-occluded and it's continuing to fill up, then you got to go in and modify what you did.
You're right. Unless the child is deteriorating. I feel like if they have an intracranial complication, usually it's about a week later. If the child is kind of doing well, that maybe neurosurgery or ICU, somebody's going to want to have another MRI. And then you're right, they're going to look opacified because we just did a bunch of stuff and it's hard to tell what is what. I don't think I've ever taken a kid back in that situation before, clinically, if they were doing better. Every once in a while, my colleague, the neurosurgical team might say, hey, we have to go in now and address this. Do y'all want to do anything?
And then I'll say, sure, I'll clean out your nose, right, kind of thing. All right.
Yeah. Or sometimes I don't always, because it just kind of depends. Because you're right, maybe it's just some blood clots. Maybe there is a little bit of pus, a little dishwater. Does going in and doing that, is that going to make or break the outcome? I don't know. And so those ones I kind of, unless it was just really bad the first time around and there's probably some more pus. You know what I mean? I think you're right. It probably is a little bit more of a gut feeling on that one. In terms of cavernous sinus thrombosis at y'all's institution, are y'all usually doing anticoagulation? Does HEMONC get involved? What's the course on that?
Yeah, for sure. Hematology gets on board as soon as they see it, and they are pretty pro anticoagulation. In the past, it used to be forever. I mean, I would always be like, oh, there goes 6 months of being on anticoagulation. And really, they do base it now on MRI. So they'll start them, I'd say average, you're looking at 6 weeks to 3 months. These kids are getting serial MRIs to make sure they're getting flow again. Obviously, opthos following them closely. And, you have to make sure that your source of infection is gone. Not forgetting things like adenoids. I know it sounds crazy, but if you have a kid who's got isolated sphenoid infection and 100% adenoids, like, is there a biofilm there that's just going to, reflourish? And, it won't happen while they're on 3 IV antibiotics, but it might when they get off all that. So just making sure that you're managing the entire nose. You don't always think of that when you're dealing with acute forehead pus, but in younger patients, meaning kids under 7, it's worth keeping that on the back of your radar as well.
No, I'm glad you brought that up because every once in a while, like you said, a younger kid, what's the role of adenoidectomy in the acute setting when there is a complication? And is there a role? And when do you consider just, hey, we're going to cauterize this while we're here?
If I look at the nose, when we start the case, it's a kid under 7 and you're dealing with like ethmoid and maxillary disease, because that's basically the sinuses that they have pneumatized at that age. And it's an orbital complication, then I am definitely not opposed to taking out adenoids. I've had to go back on people that have been operated on by, say, my partners and do an adenoidectomy a month later. You really got to think about source control, right? It's really, what it is. And if these are the kids who have 10 colds a winter and, we know that their biofilm is covered in Moraxella and we need to get rid of it, then you got to get rid of it. So, and it adds 20 minutes to the case on a case that you already spent 2 hours on. You might as well, nip it in the bud.
And every once in a while you will get, and again, it's going to be a little bit more common with the IPUS in terms of under 7, but you do get intracranial complications in the under 7 too. And I know for my kids, the younger ones, it's usually that 18-month-old that keeps getting preseptal cellulitis every 6 to 8 weeks. When they're cooled down, then we'll go ahead and take the adenoids out. There's nothing else I'm going to do at that point. But I always used to kind of think about it in the back of my head, okay, I'm in the OR for this test because either the kid has, whether it's meningitis to, what am I trying to say? Not preseptal, abscess.
Subperiosteal abscess.
Thank you. Or a subperiosteal abscess, and the child is 8 or 6. Do I need to look at the adenoids in this, or do I need to I'm there with the Bovie, should I just kind of buzz something? There isn't data or literature on that. Is there? I mean, it's true. Now I feel okay, good. I have somebody else that, also thinks about that. And then I'm okay.
Well, we're so focused on, especially with eye, getting the abscess drained, right? And making sure that you take down that lamina and get, the whole pocket out, because those are the kids that if you don't drain it, because their eye never gets better. Everyone's so focused on making sure you drain that abscess. But again, you got to really think, like you said, about source control here. And I'm definitely not opposed to doing an adenoid in the middle of an acute sinus surgery. So,
yeah. In terms of follow-up, let's say the child gets better and they're discharged. What's your follow-up like? And do you follow them long-term?
I do. So I bring them in 3 weeks and I check their nose. In little kids, I do it with a headlight and a speculum. In older kids, I do a true nasal endoscopy and debridement. And then I really dig into the history pre-infection, right? So if this is an allergic kid who occasionally takes Zyrtec, but never really had testing or, management, or, if this is a teenager who this is the first time they've ever had a sinus infection. So how long I follow them really depends on what their pre-infection history was. I do in-office allergy testing and, management. And so I kind of keep them all in my rhinology clinic so that I can address their whole nose, because that's the number one thing parents ask you, right? How did it happen? Is it going to happen again? Is every time they get a cold, do I have to worry she's going to have an orbital abscess?
So is my reasoning of it's just really bad luck? Is that not good enough? Because I feel right? It's otherwise healthy kids that don't really have a history. And maybe there could be a mild, they have allergies, but that is an issue, but I feel is that not a separate issue?
Well, it depends. It's pretty rare, honestly, that I get a kid who rolls in who's had chronic sinusitis and then gets an acute one, because, they're dealing with chronic sinusitis, not acute. These are not tonsils that have had 7 streps. Like this is a sinonasal cavity that, and you're right. And sometimes it is, especially that's why we've been so interested the last 2 years. These kids haven't been sick for 2.5 years. And then all of a sudden you get a strep in there and your body's like, whoa, what is this? And then just can't manage it and it moves too quick. So you're right. I do tell family a lot of it's bad luck. The chances of someone coming back in with a separate intracranial abscess that, is 2 years later, like kind of thing. I've never seen it. But I have had, like you said, little kids come in with a couple rounds of pre-septal. And the one time they managed it with Augmentin, the next time they needed IV Unison, and then the third time. And so that has happened. But I haven't had kids drain abscesses that came back 2 years later with a second one.
I haven't seen that either. And then if you do see something like that, or now they have a new mastoiditis or something like that, then immunology or somebody else needs to get involved in terms of why, or a immunization history. My question for you is, do you ever follow these kids like 6 months to a year out for any like CRS type potential complications?
That's a good question. I don't. Like I said, I normally see them probably 2 visits after their surgery. So I see them at 3 weeks, and then maybe I see them another 6 weeks after that, just to make sure that, hey, we're off our washes by now. Yeah, we did our Flonase. We're looking better. Because when you see them at 3 weeks, they're still probably on IV antibiotics. So they're feeling good because they're still on systemic treatment. So you just want to make sure their nose doesn't blow back up again after, you take them off all that stuff. So that's why I do a couple of visits. And then normally I don't see them yearly, or, stuff after that. And they tend not to come back, like people come back when they have trouble, right? Like they'll call you and, and their parents are more alert to it because of the trauma that they had from going through this, process in the first time.
Well, and every once in a while, if the, initial neurological symptoms were something like aphasia or upper lower extremity weakness, those kids go to rehab and they do better, right? The studies have shown that their neurological symptoms, unless it's like seizures, and even that most of the time, they tend to resolve and they get better, and it might take a little bit of time. So some of these, the recovery it can be very indolent and difficult, and it can be very traumatic. An otherwise healthy middle school kid, like it's a lot. They've missed a ton of school and now they have to really they're weak, and yeah, it can be a lot.
Yeah, it's like a parent's worst nightmare,
Yeah, absolutely. So I would see them back about 2-3 weeks after discharge, just make sure they're doing the rinses, making sure nothing new has collected on my exam. And then usually at that, I'm looking in with like a otoscope in their nose or anti-rhinoscopy. And then I'll see them back probably about 4 to 6 weeks after that. And by then, usually they'll have had a cheetle, but they have an MRI or something, right? And then at that time, depending on their symptoms and how they look, depending on age and sort of what exactly am I looking for, I might put a camera in just to kind of see. Sometimes I'll have older kids that stop rinsing at 3 weeks and they drive me crazy because I'm like, hello, like, did you not see what just happened? Like, let's make sure there's no pus, and maybe they still have a headache and things like that. And then early on, I would follow them to like 6 months and even a year because I was like, maybe I scarred them up, caused chronic sinusitis or something. And given that it was done in an acute setting. But fortunately, even with scarring in the nose, knock on wood, a lot of times children are asymptomatic. I don't know if you have any thoughts on that.
Well, the thing to think about too, you're right, is the frontal, right? Especially in a teenager. I think ensuring that is not scarred down. I see a lot of like inferior turbinate scarred to lateral wall kind of scarring because, the nose was inflamed. You scraped it up 10 times when you went in with the camera, like just trying to see. So you'll see those little scar bands here and there, but, is the frontal truly patent? And then, I get the question from parents is, what happens when they get another cold? Are they more predisposed to having this happen because the pathway has already been created, right? So the question, especially if you had blowout of the posterior table or, do I need to be more proactive? And I tell families, yes, this is not a kid that I would sit on 2 weeks of nasal drainage, and before I see the doctor. We always tell people, 10 days before you get put on an antibiotic or, you got to have symptoms long enough. And I'm like, hey, if this kid starts to pour yellow-green drainage out his nose and spike a fever, you're going to do your antibiotic washes and you're going to call me or your pediatrician and we're going to start Augmentin. We are not going to hang around and see if this spreads intracranially again. And parents are hyper aware to that because they are traumatized from what happened. And is there data to support that? I don't know. I don't know that. Like I said, I haven't really seen anybody come back with a repeat frontal from a separate infection that's greater than 6 months from the original thing. But I also have people that are treated with just IV antibiotics for intracranial complications. And then those are the kids that I actually worry more about. And those are kids that actually get more imaging, right? Because we are so nervous that we didn't take them to the OR. And so do they need MRIs every 6 months, or 3 months, or, especially in the beginning? I have one kid that they're following that has had an MRI monthly for the past 3 months to make sure that it has resolved. And his frontals look beautiful, but then they asked me, well, do you need to do sinus surgery on him to prevent this from happening again? And I'm like, well, your frontals look so beautiful. I'd hate to scar them up So those are conversations that you get too. Should you do preemptive sinus surgery if you didn't have to do it the first time, but we should do it to prevent this from happening again? And so unless there's some true anatomic, like, a huge agar cell or a frontal that has 4 cells up through, and that frontal's never going to work, or they still have residual mucosal inflammation 3 months after IV antibiotics, then, it's a different story. But when your frontals look beautiful because you've been on 2 months of IV antibiotics and, your MRIs are clear, it's hard to just say, okay, let's just do sinus surgery to say we did it,
Yeah, and like you said, it could just scar it up, and it's hard to say what are we doing? Especially even if we say anecdotally, have I seen this happen in the same kid twice in 10 years? You had mentioned antibiotic rinses. What do you have them put in there?
Sure. So I do a lot of mupirocin. I know it's not awesome for getting it to solubilize, in there, but I definitely do it because, you're dealing with staph and strep. I mean, it'd be easier if they were growing out Pseudomonas like the CF kids, because then you can just get them tobramycin in little vials and, pour that in and it mixes better like when you do budesonide. But I do. Again, I know there's not a ton of data to show the difference between saline by itself versus saline plus mupirocin, but I figure if we can get some antibiotic up into that cavity, awesome. I mean, when we flush out a neck abscess, we flush it with antibiotic saline, and I think of doing the same with sinus rinses, and it's not overly expensive or burdensome, and if they're already washing their nose, cool, put some antibiotic in there and rinse it through. So
do you just tell them to I would just tell them to do like a dime size amount or something, and then
I tell them like half a teaspoon, just give it a good squirt, and then I tell them if it still looks like a clump in the bottom, you can microwave it for 10 seconds and then just wait for it to cool down before you rinse it back through. But normally if you give it a really good shake, you can get it dissolve a little bit.
No, that's a good tip. And then do you ever do budesonide rinses in these settings?
For sure.
Okay.
Yeah, I think, if you're really worried about edema, you can do both. You can put your budesonide in the bottle and your mupirocin and just double rinse. Because just telling a kid to go home with 2 sprays of fluticasone, you're not getting it up into the frontal. And the teenagers, they're just like, meh, I barely hit your septum, let alone get it high enough to do anything. So I think acutely for the first month afterwards, you could do budesonide and, mupirocin together.
I like that.
We do get some pushback on covering budesonide, so that can be a pain, but I think it's worth getting topical steroid into the area.
Well, we're coming up to the hour. What else am I missing, Amanda? What other pearls or lessons in your career or anything else specific to intracranial complications of acute sinusitis in children?
Yeah, I think you just have to set yourself up for success operatively. When you're going to go to the OR, you have to make sure that you've got all of your tips ready to be able to see, make sure you're in the right spot, be able to control bleeding, like I said, using your 70-degree scope, using a fat scope, positioning the patient appropriately, using topical epi, really, like I said, not being afraid of a middle turbinate to take it out. All those things really hopefully will make you a more successful acute sinusitis surgeon so that you can get through those challenging cases and then you don't have to bring them back in 2 days because you didn't really get that outflow tract as open as you needed it to. So I think those are really important from an ENT standpoint of how to manage these people. Then obviously the collaboration between your subspecialties is really important, with neurosurge, ophthalmology, and infectious disease being your top 3 people that are always making the decisions on these kids in terms of who needs to go to the OR and how quickly.
Absolutely. Well, thank you so much, Amanda. I really appreciate your time. I always love talking shop, if you will, with you. Are you on any social media if our listeners wanted to reach out to you?
Yeah, I mean, we have all our PIT social media. We have the usual kind of Twitter and Facebook and other streaming stuff that we'll try and post this podcast on for people. And we do check that. We have a pediatric PIT ENT feed, and we try and keep things open for people to see what we're up to.
Awesome. All right. Well, thank you for coming on today. To our listeners, thank you for stopping by. Please reach out to us if you have any comments, questions, suggestions for topics, guests, or if you ever want to come on the show.
Awesome. Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Ivan Orgodzinsky.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.